Welcome to Health Matters, a show about what matters in your health here in Central Massachusetts. My name is Jay Broadhurst. I'm your host for this evening, and this is a production of the Worcester District Medical Society and WCCA TV. This evening, we're going to be talking with a wonderful guest about a difficult subject. The overall subject is cancer, and my guest is a specialty in surgical care of people with pancreatic cancer. So I'm going to turn to James Lindberg. Dr. Lindberg, welcome. Glad you're here. I wanted our audience to know that you attended medical school at the University of Massachusetts Medical School right here in Worcester, Massachusetts. After you left, you went off to do your surgical residency, I think at the University of Virginia.
Correct.
And then on to MD Anderson Hospital in Houston.
Correct.
Is that right?
Yep.
Texas, a hospital which has got an international reputation for cancer care. And then we sweet talked you into coming back to Worcester. Is that right?
That's correct. Yeah,
Very good.
Absolutely.
You are, I believe, called a surgical oncologist. And oncology is the medical term for cancer care. I wondered if you could just spend a few minutes talking to me and our audience about surgical oncology and how it fits in caring for people who are living with cancer.
Absolutely. It's a great question. And so my role in the care of patients with cancer is really to focus on the surgical removal of their disease. But I do that certainly in concert with other cancer care providers, including medical oncologists and radiation oncologists, just to name two. Really, the role of the surgical oncology provider is to try to devise ways to remove the tumor, but maintain functional quality of life for patients where whatever is removed, I like to joke, we don't have any spare parts. So I have to reconstruct everything afterwards
Right.
with what we have behind. And so one analogy I usually give is that I think about cancer as a weed growing in your garden. Think about a dandelion. And hopefully we get to there when it's a nice yellow flower that hasn't blossomed into seeds. That's sort of the pre-cancer stage. And as a surgeon, my role is to go in with my shovel and try to remove the area of disease without causing any damage to the rest of the garden or your yard. Whereas the medical oncologists, they tend to come in when we do have that tumor that's gone to seed, and hopefully if there are seeds that have blown away by the time we've arrived, they can lay down a weed killer. That's what I think about for chemotherapy. Whereas radiation oncologists, it's almost like they have a blowtorch and they're going out there and blowing the head off that weed to try to solve a local problem. So in simplistic terms, I've got a sophisticated shovel and I try to remove the tumors without causing too much harm.
Right. Now, I just thought about this. I'm a family doctor, as you know, and I've been intrigued by the concept of, I don't know, teaching cells how to go into a human body and find a cancer cell and destroy it. And I think this is kind of an immunotherapy type of approach, or you're trying to fool around with the immune system to fight cancer. Is that something that is something that you deal with very much in your specialty area of cancer, or do you have comments about that more generally?
Sure. So that's definitely the domain of the medical oncologist. But as someone who works closely with the medical oncologists, we confront the use of immunotherapy constantly for a number of different tumor processes. The classic tumors that respond beautifully to immunotherapy are melanoma and certain lung cancers, and increasingly we're using immunotherapy for other gastrointestinal cancers like esophagus, stomach, and colon cancers.
Wow.
And the idea is that we're able to train the immune system to recognize the abnormalities on the cancer cells and then use your body's own immune cells to specifically target those abnormal cells while sparing the normal cells that you want to keep behind. On a day-to-day basis, the medical oncologists are the ones that deliver that therapy, but I interact with patients in and around the immunotherapy, which is given either before or after my surgical therapy.
Got it. So you just mentioned skin cancer, melanoma, which used to be just frightening, but we're in better shape with that. And the other, I know you mentioned some of the GI cancers. so stomach-related cancers. There was another one sort of in between, I think, that you had mentioned.
Some certain lung cancers
Lung
are
cancers, some of the
particularly
lung
susceptible,
cancers.
yes.
Blood cancers, things like, I don't know, lymphoma or leukemia, things like that, are those handled with immunotherapy at all? Do you know? Or
Yep, there are different immunogenic modalities to treat blood cancers from solid tumor organs, but that is certainly an expanding area of
Okay.
research across
All right.
the spectrum of cancer care.
So I'd love to sort of dive into your particular interest, and I wonder if you could share with our audience the kind of cancer areas that you are particularly interested in and provide specialty care for.
Sure. So I'm our section chief at UMass Memorial for the care of abdominal and endocrine cancers. And the focus of my practice really is in pancreatic cancer care, liver and gastric cancers, and then metastatic tumors that have started at one site, either in the gastrointestinal tract or elsewhere, and spread to other organs within the abdominal cavity. The bulk of my practice, though, is in pancreatic cancer care, identifying individuals at risk, screening those individuals, and then treating cancers as they arise.
Well, when you say pancreatic cancer, to me as a family doctor, it gives me the shivers because we've got this organ, and maybe you can talk a little bit about kind of where it is and what it does, but there's only one of it. So it's not like if you've got kidney cancer, maybe you can take out a kidney and you've still got one left, or certainly with lung cancer, you know, you could take out a piece of the lung and you've got lots of lung left, but you can't take out the pancreas. I mean, you can take out the spleen and we can get along without a spleen, but the pancreas, if you took out my pancreas, what are my chances?
Sure, I can actually, believe it or not, I can't take out your whole pancreas. You wouldn't necessarily enjoy a terrific quality of life. You'd be
Really?
a brittle diabetic, but you can live without a pancreas. And most of my work in operating on patients is taking out a portion of pancreas and leaving enough behind to sustain patients. But the pancreas, you're right, is a tricky organ. We have a lot of sayings in surgical training, which is a long and arduous process, and one of which is eat when you can, 2 is sleep when you can, and 3 is don't mess with the pancreas, because it tends to be a very unforgiving organ. And you're right. You know, we don't have a spare pancreas to rely on. You have one, and you've got to treat it right. And when we have to operate on it, it tends to be a difficult process. The reason being is that it's behind all of the other organs. It sits in the back of the body, and it sits on top of some critical structures that deliver blood to and from the intestines. And so sometimes when you have problems with the pancreas, it'll involve those vascular structures of the other organs in that area, which makes operating in that space sometimes dangerous and oftentimes difficult. But the main jobs that the pancreas does, number one, is it helps to regulate your blood sugar and digestive function through secretion of hormones. And so absent a pancreas, you'd be a diabetic and need to do insulin shots continuously to manage your blood sugar. And the other important jobs that it does, or job that it does, excuse me, is that it makes digestive juices that are delivered into the intestine and helps to digest particularly the fats and proteins in our diet. And so it's interconnected to a number of different processes inside the abdomen, and it's truly a critical structure.
And it's tough to get to.
Correct, yeah.
Sounds like.
I always joke it's nice to operate on those organs that are right up front, because you can see them easily.
As a family doctor, I might do some surgery on the skin, you know, where somebody's got, you know, a mole that maybe is a little suspicious, and I can take that off. But, you know, once you get deeper, it's tough. And I wonder that is part of what makes pancreatic cancer difficult to treat, I'm sure, is just surgically, can you get to it? Are there other aspects of pancreatic cancer that make it difficult to treat?
Sure. I think the number one issue initially is that the vast majority of people who are diagnosed with pancreatic cancer are diagnosed at a later stage.
I see.
It's only about 20% of our pancreatic cancer patients who are diagnosed early on, when the disease is confined to the pancreas, where we have a potential to combine surgical removal along with typically chemotherapy with an intent towards curing the patient. For that other 80%, either the disease is wrapped up around those critical structures that can't be removed, or has already spread outside of the pancreas to other sites where surgical removal doesn't add a particular benefit in terms of long-term survival and improvement of symptoms. Part of that is that, again, the pancreas is well away from things like or not well away, but it's away from things like the digestive tract, the colon, other areas where you might develop bleeding or blockages, which would key you in to an earlier diagnosis. So that's a particularly difficult aspect of pancreatic cancers, which is find it later on.
Right. That's actually a good point. When I think about when I'm talking to patients about screening for cancer, we talk to women about women and men actually about breast cancer, and there's some imaging techniques that can help there. And then with colon cancer, people get asked to either have stool samples checked or perhaps a colonoscopy where you can actually go up and look and see if there's something that looks abnormal and grab it and then send it to the lab and find out. What are the ways you can find out if you've got pancreatic cancer?
Well, the sad truth sometimes is that patients present with a new finding incidentally. They come in with a scan or get in an accident, have to get imaging on their abdomen, or they get routine blood work that show abnormalities, and then we're keyed into a problem that leads to a test that leads to the diagnosis. One thing that we're particularly interested in is identifying a population of individuals who are at particular high risk and then devising a screening strategy for them to identify problems early. Those individuals include people who have multiple family members affected with pancreatic cancer, particularly first-degree relatives like parents, siblings, or children. Other individuals who have known genetic mutations that put them at higher risk for developing pancreatic cancer, or individuals who have particular findings like cysts and other issues inside the pancreas that lead to the need for long-term screening. And when we do screen them in the high-risk clinic that we have, we either do an MRI image,
Right.
or an endoscopic ultrasound, which is a test with our gastroenterologist where they're able to do an ultrasound of the pancreas through the wall of the stomach.
Through the inside, sort of inside out.
Correct,
Or
yeah.
Inside. I see.
And
Okay.
occasionally we do some blood work and we do a clinical exam, typically on an annual basis, as long as there's not findings that require a closer look.
So the high-risk folks, if you've got a family member in your immediate family, mom, dad, brothers, sisters, or if you've got a child that have been diagnosed with pancreatic cancer, that's a big one. How about aunts, uncles, grandparents? Not so much risk or a little bit of risk?
Well, what we understand the most about risk is if we just walked outside and you point to anybody out there and you asked me what that person's risk of developing pancreatic cancer over their lifetime, it's about 1.5%, and that's just population statistics. About 60,000 new cases of pancreatic cancer are diagnosed in the United States every year. When we start looking at family history, really we look at the impact of first-degree relatives on that risk, and we think that it's about a 4.6-fold increase if you have one first-degree relative, 6.4-fold with two first-degree relatives, and all the way up to an 18-fold increase if you have 3 or more first-degree relatives. So we do account for second-degree relatives, particularly if you have a single first-degree relative. We look at then the rest of your family cohort to decide, do you fall in a high enough risk category to screen? Typically, one first-degree relative plus any relative on that same side of the family would make you eligible for screening.
Okay. And it sounds like that's a big one, is the family history.
Correct.
Let me just turn to our audience and say, you're watching Health Matters. This is a joint production of Worcester District Medical Society and WCCA TV. I am with Dr. James Lindberg, who is a cancer oncology specialist at UMass and has a particular expertise in pancreatic cancer, and we've just been talking about screening and who might be high risk. When you is getting screened for pancreatic cancer something that anyone calls up and says, I'd like to be screened? Or do they wind up needing to have a conversation with a member of your clinical team, for instance, to find out if they're a high enough risk to warrant the screening?
Yeah, great question. So we're always willing and able to answer questions, but we certainly want to respect people's time and the expense to both the individual and the healthcare system about the costs associated with
Yeah,
screening.
because you've mentioned some tests. An MRI test is a pretty expensive one. Certainly, if you're going to sweet talk one of your GI specialists into putting a tube into somebody's stomach to do an ultrasound, I expect that's a bit expensive too.
And there's, dollar costs, but there's also costs to the individual, right? People have a lot of anxiety around these tests, and we find things incidentally sometimes that require further workup and further anxiety. So generally, patients get referred to us by their primary care physicians who have relationships with the patient. But we certainly are available to take calls and answer questions about eligibility from individuals. And we have a number staffed by our nurses within the clinic who help to triage patients. And those who are eligible, we can get in and take the necessary steps to get them the diagnostic tests that they need and enroll them in our screening protocol.
I see. So if I have a patient as a primary care doc, and they've decided that they're going to do one of the 23andMe or other genetic tests. And you mentioned that there's some genetic markers that are associated with pancreatic cancer. And they get a report back that says, oh gosh, you've got an increased risk of pancreatic cancer. Does that person come straight to you guys, or do they wind up needing to talk to a genetic counselor who's got a better handle on exactly what the relationship is between an association as opposed to something that is causally related?
Sure, we can help parse that out for them. The ideal scenario, though, is that test is ordered by our genetic counselor, and our genetic counselor is able to follow up with them to review results.
Right.
Particularly because I have expertise, obviously, in the pancreatic cancer field. I may not have a great deal of expertise about the other findings that show up on that genetic test.
So you're a surgeon.
Correct.
And I'm not. So I'm eager to learn from you, and our audience, I know, is eager to learn how do you operate? What are the surgical advances that have occurred likely I know in my lifetime, but maybe even in your lifetime?
Yeah. So we do a number of operations on the pancreas, but largely they're broken down into two main operations. And really the operations that we do are dictated by where the problem is in the pancreas. As I mentioned to you before, we try to preserve pancreatic tissue and reconnect it to the digestive tract in a way that allows the pancreas to function as normally as it had before we remove a portion. So when we have problems in the front part of the pancreas, called the head of the pancreas, the operation that we do is something called a Whipple procedure, which is very complicated because in that part of the body, the bile system, the intestine, the pancreas, they're all interconnected. And so it's like that automotive or computer part where you might have one part that goes bad, but you can't just remove that one valve or one wire. The whole thing has to come out, and then we have to reconnect it. That operation takes 6 to 8 hours.
I was going to say, I have some medical students that I look after who have been on your service and have assisted in this kind of a procedure, and they're there for hours.
Yeah, so it's a long haul, and it takes some time for patients to recover, but there's been great advancement in the care of patients in and around the operation. I think we do a much better job in 2024 of identifying who's going to be a good candidate for that surgery, and we try to build patients up through what I call prehabilitation beforehand to turn maybe marginal candidates for surgery into much better candidates for surgery. So that's one way where we've really improved outcomes. In 1980, if you went and had a Whipple operation, the rate of, or the risk of dying from the actual surgery was almost as high as 25%. Now, nationally here in the United States, that risk is less than 3%. And I think it's from identifying better candidates for surgery and then taking care of them in and around the operation in a much more sophisticated way.
Okay.
The other operation that we do is something called a distal pancreatectomy, where the middle and back part of the pancreas aren't necessarily connected to the digestive tract in a similar fashion. They're really just connected to the vessels that go out to the spleen. And so sometimes we have to take the spleen out as part of that operation as well.
Okay.
So that's a little bit more straightforward and easier to recover from. Problem is we don't see a lot of patients with cancers in that area because you're much less likely to have symptoms from a tumor in that area in an early stage. And then one of the great advancements that I think we've made recently, in addition to doing prehabilitation, better patient selection and care in and around surgery is we've really embraced the role of robotic or more minimally invasive techniques in the care of patients. And robotic surgery really is the forefront of how we're going to treat this disease surgically going forward.
So that's part of your armamentarium.
It is, yeah.
good.
I think the robotic approach is very helpful for patients. We're able to transition from making, a 1-foot incision from their breastbone to below their belly button and having a week stay in the
Great big,
hospital.
kind of wound, and now you do smaller incisions.
Exactly. We make a few smaller incisions. We're able to operate inside the abdomen under a very magnified, zoomed-in camera, and we have very fine instrumentation that allows us to do the kind of delicate work that we would normally do with our hands in an open procedure as safely and as effectively as we would have historically done open surgery. And I think the benefits are that we're able to take, again, more marginal candidates for surgery and get them through a difficult operation and certainly speed their recovery by using this approach.
Wow, that's a impressive kind of thought, and I can imagine you in this hood thing with your hands on devices that then drive these instruments that are on the inside. And do you do that by yourself, or do you have somebody else in assisting and watching and whatnot?
Sure. So generally, patients don't have a lot of understanding, as I would expect, of what robotic surgery entails.
That's why we have this show.
And I tell the joke that I don't connect them to the robot, hit remove pancreas, and go to the golf course. I actually have to do the operation.
Exactly.
And so I have a number of people assisting with the operation. So I'm at the robotic console, and I'm controlling the instruments that are inside the abdomen, but we have the anesthesia team, of course, who needs to take care of the patient.
Take care of the patient.
And then I have assistants who are at the bedside who help to exchange instruments, deliver needles and supplies that I need. And there's at least 2 people at the bedside doing that. And I'm right next to the patient operating the robotic controls and controlling the instruments on the inside of the abdomen that are conducting the operation.
I see. Well, from the patient's perspective, I'm glad you're doing that work, because I'm sure that I'm not in a way to do that. The incidence of pancreatic cancer is not tremendously high, but the mortality, the disability is problematic. And it takes a team to try to address this problem as effectively as possible. Could you tell us a little bit about your team at UMass Memorial?
Sure, that's a great question, and you're right. It's a devastating disease. We estimate that it'll be the second leading cause of cancer death by 2030, and it certainly requires more than just a surgeon to take care of these patients. And I'm blessed at UMass to work with a great group of people, from world-class medical oncologists, radiation oncologists, radiologists, and gastrointestinal doctors who are on the forefront of the diagnostic aspect of the disease. But really, the unsung heroes are sort of the nurses within the cancer center, the physical therapists and nutritionists who help to optimize our patients, the social work team and case managers who help to navigate all the challenges that go along with living with cancer.
Right.
We have a wonderful palliative care team at UMass as well, who are expert in helping symptom management for patients along the way. And we have great support from the community, believe it or not. There's a group that I work closely with called the Pancreatic Cancer Alliance, who are a group of volunteers who help us raise money for cancer care and support patients throughout their journey.
So that there is help that may come through the institution. Everybody is well aware of our, third-party payment system and insurance, and sometimes it pays for things and sometimes it doesn't, and it can be difficult to navigate. But you said social workers who are part of that team that can help people navigate the financial kind of end of this.
Yeah, exactly right. A cancer diagnosis never comes at a great time, right? And so there's always other things that are going on in people's lives, transportation issues, challenges getting to and from visits, challenges of the costs associated with care, and they, again, are expert in helping to manage those issues.
Do you have patients who, for whatever reason, have learned about, have come to you early enough in their disease that you've, along with the team, been able to operate and provide other appropriate treatments and that they've done well and lived long and prosper? Or is this, because in my history, pancreatic cancer was one of those things you just didn't survive. And Lord knows there are a number of high-profile people in this world who were tremendously, I'm thinking of Steve Jobs, head of Apple, and I think he died of pancreatic cancer, as I recall. And I just devastating. And I wonder, I want you to give us some hope.
Sure, absolutely. So, as I get further and further along in my career, I have those, long-term survivors who keep showing up. For each gray hair I get, I have a new patient who's a 5-year survivor.
Good.
No, so the statistics, you're right, have historically been very difficult with pancreatic cancer for a lot of the reasons that we've alluded to. The 5-year survival has risen for all stages of disease from a dismal 3% a number of years ago, now all the way up to 13%. That doesn't sound great, but part of that rise has been for those patients that we're able to identify early, and in the most, treat the most aggressively, we've seen 5-year survivorship rise to as high as 35% for this disease.
Wow.
In most recent studies where we've been able to operate and treat with aggressive chemotherapy, we've seen median survivals, or if you look at 100 people, how does the number 50 in the line do, has extended out to almost 54 months, which is a significant improvement.
Right.
I always counsel patients that about 1 in 5 patients are disease-free at 5 years. The challenging part, of course, is that we don't know, just sitting here chatting, who that
Right.
1 in 5 is going to be.
Exactly.
And here are the strategies that we have to optimize things to hope to get you in that 1 in 5.
So we're going to need to wrap up, it turns out. And I want to give you just a moment. Are there clinical trials that are available at UMass?
Sure. So one thing that we're hoping to do in getting that 20% number of identifying patients with early disease and increasing it is to try to better identify patients who we can screen,
Right.
develop better biomarkers to test in
Right.
the course of that screening, and better refine the screening protocols that we have. And so we are a participating site in a trial called the PROCEED Consortium,
Okay.
where we take all of our high-risk patients, which amount to roughly 300 people, and we combine that with over 50 centers internationally to
Yep.
make that 300 number now 10,000. We
So-
follow them for 10 years, and we figure out what we should be doing.
Sadly, we need to wrap up. And I just want to thank you, Dr. Lindberg, for joining me today to help our audience understand about the hope and the promise that's part of treating pancreatic cancer. My name is James Broadhurst. I want to thank you for joining us this evening for this show. I want to thank Dr. James Lindberg, who has been my guest. I would like also to thank Mr. Frank Rocco, who is our terrific engineer, and make sure that you can see and hear our show clearly. So thank you for joining us, and have a great day.